Good morning, good afternoon, good evening, depending on where you are in the world. We're very glad to have you with us today on this webinar series of ours. Today, it's going to be a lot more different than any of the times we've had. We're very excited to have with us a number of panelists who are going to join us today. And just as I get ready, again, today we're going to be talking about COVID-19. Africa's response, and with me today, we're going to be looking at the case of Uganda. Once again, my name is Kilian Songwe, and I'm with a Global Healthcare Public Foundation. So, just to be able to get started, I have some very eloquent panelists with me. Joining me this afternoon is Dr. Susan Nabadda Needle. She is the commissioner of the Uganda National Health Laboratory Services and the Central Public Health Laboratories, Ministry of Health. She holds the highest technical position in the laboratory health sector. Susan has served as the head of clinical laboratories of Mulago National Referral Hospital for the last 5 years, or for 5 years before being appointed to head of laboratory services at the Ministry of Health. She has also played a leadership role in East and Central Africa as the Secretary General of the Association of Pathologists for East, Central, and Southern Africa. She holds an undergraduate degree in undergraduate medical degree, a Masters of Medicine in Pathology from Makerere University. She did a fellowship in hematopathology at the McMaster University, Ontario, Canada. She's a fellow of the College of Pathologists of East, Central, and Southern Africa, and a member of the Association, of Pathologists of Uganda. She also holds a master's degree in administration, leadership, governance, and public finance management. I'm just going to do all the introductions now so that when we get to our speakers, they will just go in and speak. The next speaker with us is Dr. Lisa Nelson, who joined CDC in 2017 as the country director. Lisa joined CDC originally in 2001 as an epidemic institutional service officer in the international TB branch, and later served as TB HIV team lead in the division for TB elimination before going to Mozambique as CDC country director for 6 years. She relocated to Geneva, Switzerland as senior technical advisor in MOH HIV department, and later served as senior HIV disease advisor at the Global Fund. She served as acting chief medical officer at the US Department of State's Office for US Global AIDS Coordinator and Health Diplomacy, OGAC, within the PEPFAR program before joining Uganda in 2017. Lisa holds a bachelor's degree in political science from Yale, a master's in epidemiology and health services from the University of California, Berkeley, and a medical degree from the University of California, San Francisco. She completed a residency in pediatrics and a fellowship in pediatric infection disease in Boston. So welcome, Lisa. Joining us as well is Dr. Mankoula. Dr. Mankoula is currently with Africa CDC Incident Manager for COVID-19 in Africa. He is a health professional with over 11 years experience in public health emergency management, epidemiology, and practicing medicine. In 2016, he was selected as one of 10 African public health professionals to support the establishment and operationalization of Africa CDC under the African Union Commission. He is currently serving as the lead of Africa CDC Emergency Operations Center. He's established a coalition in collaboration with WHO and US CDC to support the agenda for the Public Health Emergency Operations Center in Africa and supports member states. He has also led Africa CDC missions in response to various outbreaks in Africa, on the African continent, such as Ebola in DRC, Rift Valley in Kenya, and cholera in Zimbabwe. Dr. Mankoula has a master's degree in public policy with a focus in health policy from the American University in Cairo, Egypt, and the Egyptian Board of Epidemiology. He has accomplished the Africa CDC Fellowship, the Public Health Emergency Management Fellowship, US CDC, and the Field Epidemiology Training Program Fellowship as well. Dr. Mankoula's mission is to improve health of people through developing policies and programs targeting disease prevention and control with a special focus on public health emergency management. So those are my three guests. And then of course, there is myself, whom you've met many, many times before now. And I'm glad to be hosting again today. And just before we get into the story today and the discussion today, I want to just quickly have some opening remarks. Africa's COVID-19 case, this was done in October, just a little over 45 days ago, neared 1.6 million with over 38,000 deaths. The continent at that point had over 1,300,000 recoveries. And that's where the continent has been at this point. At the end of 2019, almost all African countries had undertaken a joint external evaluation, commonly known as the GEE, of the international health regulation. This process helped countries identify the gaps in their ability to prevent, detect, and respond to public health threats. Many countries had developed competencies in real-time surveillance and immunizations, but overall, there was a pressing need for improving the resilience of the health sector in order to ensure effective outbreak response. In response to recommendations from the joint external evaluation, countries were supposed to develop multi-sectoral national action plans for health security, addressing gaps identified by the JEE and aligning with the various country sector plans. What we had going forward, my screen is locked. What we had going forward, therefore, was we had the first case of COVID-19. The first case of COVID-19 was reported in African region on the 14th of February in Egypt, and in sub-Saharan Africa on the 27th of February in Nigeria. This was over 1 month. This was over 1 month after the first case of the disease was reported in China, giving the region lead time to prepare for a large outbreak. As local transmission superseded imported cases and the doubling time shortened to below 7 days in more than 95% of the affected countries, countries are now bracing for the impact of the pandemic. The progressive scaling of molecular testing across the continent has been impressive. Countries such as South Africa and Nigeria are leveraging and integrating molecular laboratory diagnostic capacity that exists for specific disease programs like drug resistant TB, Lassa fever, and HIV to scale up testing for COVID-19. While access to diagnostic reagents becomes difficult, countries are pioneering pool testing for COVID-19 samples, therefore speeding up processing time and population coverage. In response to the lockdown and the challenges of responding to the pandemic, innovative use of technology and new ways of working in health and other non-health sectors are being piloted. For instance, drones are being used to transport test kits and samples from hard-to-reach areas, thus reducing the sample transport time from many hours to minutes. There is a boom in local manufactured face masks, an explosion of local produced soap and hand sanitizers, and training meetings and workshops have moved online. It is important to note that the open, frequent, and transparent communication of testing results within most African countries has kept the world abreast of the progress of the disease, despite the challenges of access to testing in many countries. The emergence of trusted voices and leadership by national public health institutes like the Nigeria Center for Disease Control and 5 regional centers for disease control, and the APEX, Africa Centers for Disease Control, after the West African Ebola outbreak, has added technical rigor and improved the quality of the response by guiding political leaders to make better decisions on public health and social measures. African countries will still be stretched as the pandemic spreads across the continent and as the containment measures succumb to the pressure of time, limited resources, and increased rates of infection. In the meantime, African countries scaling molecular testing capacity, develop for other diseases, deploying trainings in field epidemiology training programs to lead the field response, and using their most precious resources, our young people, to undertake contact tracing, staff isolation centers, and provide the support care that is available. In concluding my remarks, so far the response in Africa has been marked by innovation and resilience in the face of almost insurmountable odds and in the resounding collapse of multilateralism. My remarks, for the most part, actually are taken from the BMC medicine report in conjunction with some remarks from the World Bank. So those are my opening remarks as we go into this. At this point, I would like to call on Dr. Susan Nabadda, the Commissioner at the Uganda National Health Laboratory Services, to please make her remarks, tell us the story of the timeline in combating COVID-19 in Uganda. What was the setup like? What have you done? What have been the innovations that you've carried out in Uganda to get this far? Welcome.
Thank you very much, Prof, for this opportunity. Good evening, good afternoon, good morning, everybody. I'm glad to be part of this webinar where we are discussing Africa COVID-19 response. I'm Dr. Susan Nabadda, Commissioner, National Health Laboratory Services, Ministry of Health, and I'm going to give you a snapshot and our timeline story for COVID-19 laboratory response in Uganda. But before I dive into it, I just want to give you a COVID update in Uganda. As by 28th of November, we had identified 20,145 confirmed Ugandans, and we've done so far 623,977 tests, and we've had 201 deaths. So before COVID came in, what did we have as the lab structure? As Ministry of Health, there was already an existing laboratory structure. We had a national task force for the epidemics that we were having. There was already a well-defined lab system framework that was spanning from the lowest health center 4 and 3, to the highest reference testing laboratories. We had an existing laboratory department that was spearheading the coordination and the testing of lab services. We already had some documents like our laboratory manual that was guiding the routine lab testing. We had already existing accredited laboratories. And as I've already said, we already had a national task force in place that was responding to disease outbreaks. In a snapshot, that's how our laboratory network is. At the Ministry of Health, we have a Department of National Health Laboratory Services, and the network consists of regional laboratories, general hospital laboratories, and laboratories up to Health Center 3. But we work in collaboration with private labs, professional bodies, national reference laboratories, specialized laboratories, research labs, and teaching hospital, on top of working with the departments that have laboratory components in them, like malaria, TB, and HIV. Still before the COVID pandemic came in, we had a number of partnerships that we are supporting the laboratory structure and the laboratory systems in the country. We have CDC, a main supporter for laboratory systems, WHO, PEPFAR, UNICEF, Africa CDC, World Bank, implementing partners like IDI, Global Health Foundation, Resolve, CHAI, Global Fund. So these were already in existence before the pandemic came in. And the systems themselves that were in existence before the pandemic came in, we had a robust national sample transport network for already existing tests like HIV viral load, where you see a hub and spoke. We have samples delivered from the lowest health center up to the hub. And hubs, we had already built around 100 hubs that were strengthened with equipment and infrastructure and good quality management systems to serve the facilities around them. And those tests that could not be done at the hub are being brought to the centralized testing, that is the reference labs that include CPHL and UVRI. And this map shows the different sites of the different 100 hubs distributed across the country, well distributed to be able to cover 97% of what we need for laboratory services. We already had a good laboratory infrastructure of the 100 hubs that were strengthened in terms of equipment, in terms of biosafety, in terms of quality management systems, and skilled human resource. We already had a set result dispatch system that was returning results for some of the tests like HIV, EID, and others. We had an established national calibration center that helps out to calibrate the different equipment in the different laboratories. We had robust quality management systems and a number of labs we have accredited, all this with support of our partners. And we had a very strong laboratory information management infrastructure for multiple health programs to be able to deliver and connect and collect data. At the same time, we had already existing centralized testing capacity at different laboratories like UVRI, Central Public Health Labs, National TB Labs, and Makerere Labs. All this was in place before the pandemic started. So how did we move when the pandemic started? In March, we're all aware our first case was identified on 21st March, but before the identification, we already had a national COVID-19 response plan in place. And when this was started, an incident management team was set up, and we had different pillars that were set up to respond to the pandemic. And the laboratory pillar was set up. And when in April, we embarked on assessing of different laboratories with support from a Global Health Foundation to look at the labs with the capacity to test for COVID. Looking at the PCR platforms we had trainings in biosafety, trainings in electronic results return. But at the same time, we developed a laboratory manual that was guiding the response. And this manual had a number of things in it. It had issues to deal with sample transportation, issues with testing strategies, the soaps we need to use, the communication strategy, and the budgets and logistics that we needed to use. So in April, this was set up. We had a number of labs assessed, as you shall see ahead. And as we moved on in June, we had an enhanced M&E plan set up. We had to refine some of the soaps depending on the dynamic of the disease, and more refresher trainings. And we were part of the East African Joint Network in response to COVID. And as we moved on in September, we came up with a new testing strategy that was looking at targeted testing. And currently that is what we are actually using. As I've informed you that we assessed laboratories across the network in April to be able to increase access, what we call the decentralization strategy. We actually have assessed and have labs that are ready, and some of them are testing up to a tune of 25 labs. The laboratories in green are the currently testing labs, but as you look at them, they are more centered in the center of the country. But when you look at our distribution of the labs that we assess, they actually cover the whole country. And this would help us to increase access to testing and access to results to people in the different areas. And on top of that, we had an enhancement by the mobile labs that were placed at the border, the southern border, the northern border, and the eastern border to combat the border point entry. So through this, through the decentralization strategy, we managed to assess and map out laboratories that would support us. And if you look at this, all the capacity put together, we can be able to put out 13,856 tests in a day. But as I speak now, out of the 25 we assessed, we have 11 labs that are currently testing. What did we exactly do as the lab? The lab-specific activities under the Incident Management Committee. One, we did specimen coordination and management through training in specimen collection, transportation, through biosafety and biosecurity trainings, access to laboratory testing. Then we also came up with technical guidance by developing the different guidelines and policies and procedures, and also guiding on the testing strategy, and also coming up with validation of some of the diagnostic platforms that we were using, especially the RDTs and the PCR. We also coordinated the supply chain by procuring of laboratory reagents and supplies through use of government of Uganda funds, but at the same time using the COVID-19 Global Procurement Portal. And we quantified and projected the lab needs that we needed. Then we came up with a monitoring and evaluation plan to be able to monitor our COVID-19 response via the laboratory procedures. We have daily laboratory, initially we used to have daily laboratory pillar meetings to review our interventions as the pandemic evolved and to respond to the demands of the incident management team, updating them and sharing the roles and the responsibilities that we had. As I've already said, we developed laboratory guidelines and SOPs to guide the response. We developed laboratory training tools, IEC materials, and risk communication materials that included RDT participants training manual, a communication strategy, and RDT training sample collection SOPs. Then we tested, and we're still testing up to now with no interruption, tests or samples that we have collected right from the response, from the national surveys and the rapid risk-based assessments. We've had over two rapid assessment surveys in Uganda to inform the response. The first one was over 26,000 samples and the next one was over 13,000 samples. But on top of this, we continue to test samples for the response and also samples for risk-based assessments. Then we continue to develop strategies to guide the response. We started with a centralized testing strategy at the beginning because these were the labs that were ready and the available reagents were for these particular labs. But as I've indicated that as we did a decentralization strategy to map out the different labs, we've now moved to over 11 labs across the country, and we are able now to test around 4,000, between 3,000 and 4,000 samples per day. But as we speak now, we are actually doing prioritized testing strategy because of so many issues, one being the availability of the reagents. We also extended our electronic dispatch system. Initially, it was for different diseases like HIV, EID, viral load to COVID-19 to cover a number of different districts and different communities that were testing for COVID. And we developed a lab M&E framework that is implemented on a daily basis. What have we so far achieved from the response? One, we've improved access to COVID-19 testing because we already had an existing diagnostics infrastructure that we backed on. We had centralized testing, but currently we've decentralized the testing and we want to decentralize to all the labs I've shown you in the map. We had laboratory competencies in sample collection, packaging, and transportation, and were able to timely integrate and deploy COVID-19 into the LIMS, the ELDS, and the risk track. We also had a very focused lab. We have a very focused lab logistics team that coordinates the logistics and the supplies, coordinates the supplies and the support from the different donors and partners, quantifies the laboratory agents that are needed, and this has hence led us not to have an interruption in the testing. We've actually never had a day without testing. Then the lab leadership. We've had a lot of support from the lab teams themselves that form the lab pillar, but also with a lot of support from the strategic and policy level, and this has helped us to move on in our lab response. Then we've had timely adoption and deployment of some of the guidelines and SOPs. It's not easy to adopt in a very emergency mode, but these manuals and guidelines have been well adopted, and we are continuing to mentor more people to adopt the guidelines. But that said, we still had some challenges. The biggest, which is common, I think, everywhere, is the inconsistent COVID-19 supplies of the test kits, sample collection materials, and PPEs. And this has led us to delay decentralization of the testing across the country. If we had it, we should have had all the labs I've shown you testing. Then the issue of emergency use of test kits with multiple protocols, the emergency authorization of these test kits and the different PCR protocols have been a big challenge. And we think some of these have caused issues in the discordancy of the test results that we receive and discordancies in the results from the different laboratories because of the different PCR protocols that are being used. But also at the same time, the biggest challenge is the little information on the COVID-19 pathophysiology. We are better than how we started, but there was a big issue about the different pathophysiology, and this led a lot to people who didn't understand the physiology to question the lab results, and this compromised the public trust. But this said, as we move on, people understanding the pathophysiology and they are finally understanding the laboratory results that are coming out of the labs. The other challenge was inadequate integration and institutionalization of COVID-19 activities into routine. It's a silo program. It began as a silo program, but our main issue now is to have it integrated in the normal system such that it can work with the systems that are already existing. As we've seen, we integrated into LIMS, integrated into sample transportation. Now we need to integrate it into the normal laboratory systems. But that said, it goes with a lot of issues like the HR, human resource that is needed to do that, and the and the other overhead costs that are needed. But that also has been a big challenge. And on top of that, the suboptimal budget and funding for the supplies and the reagents for the lab. At this, the budgets for the lab reagents, you are all aware, are very high, and it's been very hard to get the funding from the government of Uganda. But I'm happy that they've now realized and they're trying to allocate some funds to the lab. But I want also to thank the donors and the partners that have supported us in this. Because of the insufficient budgets, it has led us to inadequate implementation of our decentralized strategy that we needed to do. So what are we planning to do to improve the response? We are mobilizing and lobbying for more discrete funding for logistics for the laboratory. And this will help us to decentralize the testing, to increase access, to reduce the turnaround time, because we would have spread the testing across the country. The other that we are looking at is to roll out of the antigen RDTs as they were already approved by WHO. This will also reduce the turnaround time and increase access to testing even to the lowest health center. We've embarked on this already. We started in a phased approach, and we hope that by December we would have spread throughout the country. Also, to improve on our quality of our laboratories, we're rolling out COVID-19 EQA panels to all the testing laboratories so that we give confidence to our users that the lab results that come out of our laboratories are credible. We are also strengthening the national sample transport system to improve on the turnaround time, because the current sample transportation system would not meet the demand of COVID, because the COVID turnaround time, people want their results as fast as possible to be able to isolate patients and manage the patients better. So we're trying to improve on this and in getting innovative ways of strengthening the national sample transport system. We are also now integrating COVID-19 testing into our normal laboratory processes so that it becomes a normal laboratory test, so that it doesn't look like a siloed program. In this, we shall leverage on the different resources and funding in there to be able to respond better. And also, finally, we are implementing our M&E plan to see where we've done well and where we need to do better, to be able to monitor our response. So that is our journey as Uganda. I want to thank the Ministry of Health top leadership for the leadership and the guidance given to the lab pillar, the COVID-19 incident management team, our health development partners, especially CDC and WHO and others, the implementing partners that have worked closely with us, especially our global, but also with others. And on top of it all, the laboratory pillar team that I work with to make sure that we've achieved what we've achieved in the laboratory response for COVID-19 in Uganda. Thank you very much. Back to you, Chair.
Thank you indeed. Thank you very, very much indeed, Dr. Nabadda, for that's a great presentation, and it actually says a lot about what Uganda has done. But just before I invite Dr. Lisa, just three very quick things that you mentioned, which I think are really important. I mean, everything you said is important and useful as we look at the response to COVID. But I think one of the big ones is the integrated system, how you were able to quickly move the transport system COVID-19 samples into the already existing spoke and hub system that you have in Uganda, which is one of the big stories that is told about the story about the lab pillars in Uganda, as the whole the efficiency, the efficacy of being able to move samples in Uganda. So that integration was it was actually very groundbreaking, how you were able to fold in the COVID samples. And I think one of the other big things in Uganda is the multiplexing, how you were also able to use equipments that were originally, say, for example, the Gene Expert quickly with cartridges moving on to do COVID testing, or being able to mount your COVID testing onto other existing equipment. I think that was phenomenal. And also one of the other really interesting things you mentioned is the fact that in spite of the commodity shortage across the world, Uganda has never ever stopped testing. I think that is phenomenal for a country of what, almost 45 million people. The volume of testing that has been done is really, really very impressive. And so our sincere congratulations for the work that you've done with the lab pillar and the Ministry of Health out in Uganda. Please don't go away. Please just hold your peace. We're going to have some questions very shortly. But just before we get to the Q&A, yes, I see Dr. Nelson is already sharing her screen. Thank you so much indeed. Welcome. You have the floor.
Good afternoon, everybody. Good afternoon, Professor Kilian and Dr. Nabadda. I hope you can all see my screen, and it's really a pleasure to be here. Can you see my screen?
Yes, we can. Thank you.
Wonderful. And I apologize, I won't put on my video because of bandwidth issues, but hopefully you can hear me and you can see my slides. And Dr. Nabadda has really covered a great story of what Uganda has done in the laboratory sector. So this afternoon, I want to talk a little bit about what role CDC has played here in Uganda, not only in COVID-19, but more broadly in global health security. Talking also a bit beyond the lab sector in terms of what we've done to support emergency management systems, surveillance systems, workforce, and other key components to a successful COVID-19 response. You've already seen this slide from Dr. Nabadda, but I think it bears repeating. We really work with many different stakeholders here in Uganda, and I think that is part of what contributes to our success. And we were doing this long before the COVID-19 epidemic emerged on the scene. Just to talk briefly about CDC here in Uganda. CDC is a public health agency of the United States government, but we work in a number of key areas. Laboratory is a core part of what CDC supports in the United States and around the world. Public health surveillance and other data gathering activities, workforce development, and that is particularly training public health professionals and laboratorians, emergency operations, and real-time evaluation and research. Here in Uganda, we've been working since 1991. We started through a program called Public Health Without Walls at Makerere University that became the Masters in Public Health program, but also the Field Epidemiology Training Program, or what we call here in Uganda, the Public Health Fellowship Program. And you'll see some examples of how critical the fellows have been to the COVID-19 response. We've had a full-time director here since 1999, and our funding exceeds $2 billion a year to the health sector here in Uganda. And as many of you know, a lot of that is through our HIV program, the President's Emergency Plan for AIDS Relief, or PEPFAR, which CDC is a part of, but also more recently, our activities in global health security. So as you can see, our overall funding has been around $200 million a year. In blue are the funds through PEPFAR, or the HIV response, and in orange are other funding, particularly global health security, and more recently specific funding related to COVID-19. So what you can see here in this pie chart is that we've received to date almost $8 million specifically related to COVID-19. We've also been able to leverage or redirect existing funds, a few of that through PEPFAR, but also through our existing global health security programs here in Uganda. And we are getting more funding on the horizon through additional money appropriated by Congress for global COVID-19 activities. But CDC has been working for many years to address many different aspects of the health system in Uganda. You can see in green some of the activities we support for laboratory. In blue, the activities that we support to address the supply chain. In pink, some of the activities to address disease surveillance and surveys for a number of different public health challenges, and then health, workforce, and leadership. And you can see our FETP program, as well as support we provide directly to the Ministry of Health. We're also very proud here in Uganda that almost 100% of our funding goes to Ugandan organizations, both governmental and non-governmental. And here are just some examples. What you can see here is that we fund the Ministry of Health directly. We have also a new award over the past year to fund UNHLDS directly. We fund Uganda Virus Research Institute, and we also have 3 grants with Makerere University. And you can see on the right some of the examples of the support we provide, and that includes supporting the Emergency Operations Center and its staff, supporting infection prevention and control activities related to COVID, support to regional referral hospitals, to the labs, as we'll talk about, both UNHLDS and UVRI, as well as support through Makerere University. We also support a number of non-governmental organizations, some of which Dr. Nabadda has already talked about, AGHPF being one of them, AFINET, IDI, and Medical Access. In the top, you can see these are what we call our above site implementing partners. They work on policy development, technical assistance to the government of Uganda and others, as well as other activities. In green at the bottom, you can see we also support in 7 regions of Uganda what we call comprehensive partners. That includes TASO, Mildmay, Baylor, Rakai Health Sciences Program, IDI, which also plays a regional role, and the Uganda Prison Service. And in that case, we're supporting partners who really work at site, district, and regional level to really support service delivery for HIV, TB, and more recently, global health security, including COVID-19. So turning now to our activities in global health security and COVID-19. On this slide, you can see some photos of our CDC director's visit. Dr. Redfield was here twice in 2018 to really see our global health security activities. And when Ebola hit next door in DR Congo, he came back in August. And this just highlights that CDC has been working in global health security for a number of years in Uganda. It started in 2013 with a demonstration project. Uganda and Vietnam were 2 countries where CDC invested, and it has grown. And I think in 2018, with the arrival of Ebola in Congo, we really also were able to ramp up our activities. And as Professor Kilian has already alluded to, the Global Health Security Agenda, which CDC supports, really has 3 priority areas: to prevent disease, to detect it when it occurs, and to respond. And that is done through 11 action packages. You can see some of the activities on the left-hand side. And again, we've been supporting these efforts here in Uganda well before the COVID-19 outbreak. And why is that? Well, one of the key reasons that is known to all of you probably on the call is just the cost. And you can see in the far right, to date, an estimated $12 trillion that have come as a result of the COVID-19 epidemic. And certainly preventing these outbreaks, supporting countries to identify and rapidly respond will bring down the cost of these epidemics. As I've already mentioned, CDC really works in a number of areas, but we call these the core 4. And this is surveillance systems, laboratory networks, workforce development, and emergency management systems. And I'm not going to talk in great detail about workforce, so I will just mention here again our field epidemiology training program or public health fellowship program is one of our key interventions in workforce development here in Uganda and indeed in many countries around the world. And I'll talk a bit more about the other 3 core components of support for CDC. And I think, again, what you can see here on the right, this is one of our fellows who was screening people at the airport beginning in February, March, and our FETP fellows have really been on the front lines of this response throughout. the past year, but have also played a key role in setting up airport surveillance. Indeed, they did it for Ebola, but they've also been doing it for COVID-19. And to date, CDC's provided more than $40 million to Uganda to address global health security. So I think, as you've already heard from Dr. Nabadda, and I won't belabor it, Uganda really benefited from a lot of investment well before COVID-19 that has allowed Uganda to respond successfully in many ways to this outbreak. So turning a little bit to how we support the emergency management systems here in Uganda. Uganda has a very strong public health emergency operations center that was created in 2013. It has had more than 100 activations at this point for various diseases. It's hosted more than 79 high-level visitors. You can see our Secretary for Health and Human Services there in the middle, next to Minister Acheng. On the far left is Dr. Tony Fauci, who was also on this visit, who's certainly become famous around the world as one of the spokespeople in the United States. But the many different countries and delegations have visited Uganda's Emergency Operations Center to learn about how they do business here in Uganda. Here in Uganda, beginning in January, the EOC was activated. In February, Uganda set up an incident command structure with some support from CDC. And on March 21st, as you know, we recorded the first case. But we had already been meeting, and CDC had been supporting the EOC for a long time before that. Turning now to surveillance systems. CDC provides a lot of support in many different ways, not only to EIDSR, which is Electronic Integrated Disease Surveillance, but also as part of that and as part of the Emergency Operations Center supporting indicator-based surveillance systems, event-based surveillance systems, sentinel surveillance systems for acute febrile illness or AFI, for SARI, which is severe acute respiratory infections or influenza-like illness surveillance, ILI, as well as antimicrobial resistance, as well as supporting routine disease reporting systems through DHIS2. And I think one of the things we've been working on in the last month or two is how we can really integrate these many different surveillance systems and help Uganda to have a more holistic national surveillance strategy for COVID-19, for other respiratory illnesses, and for other disease surveillance. And you can see here another fellow here who's working on the response doing disease surveillance activities. Turning now to border health activities, which is another area that CDC has provided support. And I think Dr. Nabadda has already shared that Uganda really faced quite a challenge in April, May, June, when the airport was shut down. We were seeing very few cases here in Uganda and almost no community transmission, but we had many people crossing the borders, bringing goods and services into Uganda, and that is where many of our cases were coming from. We began our work really with the Ebola outbreak in 2018 to help Uganda, and indeed, when Uganda conducted its joint external evaluation, or JEE, in 2017, border health was really considered an area where improvements were needed. So we've supported Uganda to strengthen its border health activities, developing standard operating procedures, helping to support temperature screening, cross-border surveillance meetings, particularly with DRC, but also with South Sudan, and also mapping population movements through PopCab surveys that really understand, particularly from DRC, but also elsewhere, how are people coming into Uganda, where are they going, and what does that mean for the disease risks, be they Ebola or COVID-19. We've also strengthened IPC, infection prevention and control activities. We've helped strengthen data systems, including tracking of truck drivers and how they migrate through Uganda, strengthening screening from 3 points of entry or POEs to 65 active points of entry. and also helping to develop a framework for leadership and stewardship in districts, strengthening cross-border activities, and also working with truck drivers and truck driver associations to strengthen both surveillance and testing strategies for that critical population. So moving now to laboratory systems, and Dr. Nabadda has done really a great job talking broadly about what Uganda has done. So I'll just focus a little bit on how CDC has helped to support those efforts. So before COVID struck, we were already supporting UVRI and its National Influenza Center. We were supporting many other parts of UVRI, including arboviruses, viral hemorrhagic fevers, the plague lab up in Arua, as well as HIV. And as I've already mentioned, we were supporting the National Public Health Lab, CPHL or UNHLS, to do high volume PCR testing of HIV viral load and early infant diagnosis. And Uganda was really able to capitalize on all of this infrastructure to quickly course correct and redirect its efforts towards COVID-19. Dr. Nabadda's already talked about the specimen referral and results return network. And just to say that, yes, this system was largely put in place with PEPFAR resources for HIV testing, HIV viral load, and early infant diagnosis. But even before COVID-19, we were able to use this infrastructure for Ebola suspect specimens, as well as being able to use it in recent times to look at animal specimens, such as from anthrax, to detect and then respond. I think the electronic results return that Uganda has been piloting is also something CDC has been supporting. What you can see here, and Dr. Nabadda's already talked about this a little bit, are the over 100 lab hubs around Uganda that get support largely through PEPFAR, but have really enabled Uganda to have quite rapid results return through this hub system with electronic return of results. The other thing I would highlight is that Uganda has been able to build up a Zoom network and to use these hubs to do telementoring and visits via Zoom or communication via Zoom under the setting of the COVID-19 outbreak. So finally, as I finish up here, just a few additional examples of CDC support to AGHPF in particular. You've heard some of this from Dr. Nabadda, but really we've helped to fund AGHPF and other partners to develop a national laboratory preparedness assessment tools based on WHO guidance to support external preparedness of the 14 labs, and you've heard 11 have now been set up to perform testing. We've also supported through AGHPF the biomedical engineers to conduct servicing of biosafety cabinets at 78 sites around the country, to procure commodities needed for the testing, such as pipettes and calibration of those, as well as calibration for point of entry infrared temperature guns. And then finally, I think that one of the things that's really been critical and has been a success factor for Uganda is the rapid training that took place, both in person, but also by Zoom, to train people to correctly collect samples, to do refresher trainings for district-led laboratory focal persons, as well as these lab hubs, as well as providing technical assistance as the epidemic has evolved. And I think certainly one of the things we've learned is how dynamic this outbreak is and how we constantly need to adapt to the changing science, commodities, laboratory testing strategies, et cetera. So finally, I think we're very grateful that we've had really excellent leadership here in Uganda at all levels. We had very good collaboration with all partners in the lab sector, and I think we've been able to come together and work effectively on the COVID-19 response. CDC has been here for many years, as you've seen, and I think we were able to leverage other investments through PEPFAR, through global health security and other collaborations to quickly respond and help Uganda respond to the COVID-19 epidemic. And as I've shown you, we fund a variety of partners in the lab space, both at the above site policy technical assistance level, right down to the facility, local lab and community level. I think the incident management structure has really helped Uganda to bring all partners together in the lab pillar as well as the other pillars to respond quickly. But I think we have many challenges ahead. Dr. Nabadda has outlined quite a number of them. It is a dynamic environment. Funding is dynamic. Testing strategies and the availability of reagents are dynamic. And I think going forward, I hope we will continue to look at what the role of multiplex platforms are, what the role of point of care testing is, and as we're going to need to continue to do this for the foreseeable future, how we can ensure that we have the most efficient and effective systems possible as this epidemic evolves. I'd just like to thank many folks from my team who helped and who continue to help with the response each and every day. We have a great team who've been doing a lot of work in support of Uganda. So thank you very much.
Thank you so much indeed, Lisa. That was a phenomenal presentation, as always, very much as always. I was just looking as you made the presentation, I was actually looking at those dollar figures, and indeed that has been tremendous support from CDC to the Ministry of Health. And from us, I think I would seize the opportunity to say it has been a phenomenal working relationship with CDC and all the things that we've done in the country with your support to be able to get to achieve a lot of the progress that has been made. Looking at all the COVID testing labs, we've actually been very instrumental in actually auditing them and presenting them for certification to do COVID testing. And again, we're able to do that with the backing of CDC. So we're very thankful for that relationship. It's been phenomenal doing this work. Lisa, please don't leave. We're going to now listen to Dr. Mankoula. And Wessam, please don't worry, we have a good half hour to go on. So please, I'm going to turn over to you and you tell us about the Africa CDC's response to the COVID-19 pandemic. Please welcome.
Thank you, Professor Kilian, for the introduction. And as Dr. Susan and Dr. Lisa give a perspective from country level. So in my presentation, I speak about the continental level in Africa and the role of Africa CDC in supporting member states to prepare and respond to this COVID-19 pandemic in the continent. And in my presentation, I'll cover two main issues. The first one about the epidemiological situation in the continent. Then the second part, I'll focus on Africa CDC support effort to member states. So globally, we have so far more than 61 million reported COVID-19 cases worldwide, with more than 1.4 million deaths. And the case fatality rate is around 2.3%. PAHO region and Euro region is the epicenter for this COVID-19 pandemic so far. At the continental level in Africa, so far we have more than 2.1 million confirmed cases with more than 51,000 confirmed deaths. And the total recovery is more than 1.8 million. As you can see from the map, the first wave of this pandemic was around July, and now we're experiencing the second wave of this pandemic. In the first wave, South Africa region was the leading one for this first wave. Currently, we're noticing that most of the cases are reporting from North Africa, followed by Southern African region. And this is the cumulative COVID-19 cases by member state. At the top, South Africa, with more than 500,000 cases. Then we have 8 countries, most of them from North Africa, with number of cases between 50,000 and 500,000 cases. This table shows the number of cases reported by each region. As I mentioned, most of the cases from Southern Africa and North African region. And the region with the highest case fatality rate, North African region, followed by Southern African region. This slide is showing the new COVID-19 cases reported per million population. We have, and this is per day. So we have one country reporting more than 100 cases per million population, and this is Morocco, followed by 3 other countries reporting between 80 to 100 cases per million population per day, and this is Libya, Tunisia, and Cape Verde. And for the case fatality rate by member state, we have 5 countries reporting more than 5% case fatality rate, and we have 12 countries reporting between 2.4 and 5% case fatality rate. Total COVID-19 tests conducted in Africa so far, we have more than 22 million tests conducted in the continent. We have 10.2 tests per reported test per case ratio, a 9.8% positivity rate in the continent. COVID-19 testing performance by country. We have, unfortunately, 16 countries are doing not enough testing, less than 10 tests per case ratio. 27 countries within the recommended range for WHO, 10 to 30 tests per case ratio, and another 12 countries even above this recommended ratio, and one of them is Uganda. And for test positivity, we have 7 countries. The positivity rate is more than 10% positivity rate for COVID-19 testing. We have 6 countries between 7 to 10% positivity rate. For the travel restriction status, we have 9 countries in the continent under full border closures. Other countries, they have some travel restriction for related to entries and exit travel restrictions. Some of these restrictions may be related to prior testing, other restriction related to mandatory quarantine. And this figure as of last month. What Africa CDC response initiative to respond to COVID-19 so far? So we have 6-pronged approach. The first one, to have Africa joint continental strategy for COVID-19 response. Another one focusing on Africa task force for COVID-19 response. I'll speak in detail later about each one of these 6-pronged approach. Another initiative, it's PACT initiative, Partnership for Accelerated COVID-19 Testing, Africa Medical Supply Platform, Consortium for COVID-19 Vaccine Clinical Trial, and Africa Against COVID-19 Saving Live Economies and Livelihood. So Africa CDC, early at the beginning of this pandemic in January, we activated our Emergency Operation Center to move quickly to support member state in preparedness and response for this COVID-19 pandemic. And during this time, we prepared Africa Joint Continental Strategy to lead the response for COVID-19 pandemic in the continent. As it was mentioned previously, the first case reported in Africa was in Egypt on 15th of February. 1 week later, after the first case reported in the continent, Africa CDC and African Union Commission invited the health ministers to emergency ministerial meeting. And this was 22nd of February. And in this ministerial meeting, the health minister agreed to adopt Africa Joint Continental Strategy for COVID-19 response, and they endorsed AFCOR Task Force, Africa Task Force COVID-19, and the continental mechanism to coordinate, communicate, collaborate between the member states to respond to this COVID-19 pandemic. Also, Africa CDC worked with different organs with African Union Commission and build on the existing capacity to support member state. One of the organs that we collaborate with is peace and security. And we managed during the first wave where the border are closed and also the airspace are closed. We managed in collaboration with peace and security to deploy our rapid responders from DRC to support other countries in the continent. and using military flight from Cameroon in collaboration with Peace and Security Department. And this is the first time to use this airlifting capabilities of African Union in collaboration with member states to support respond to outbreaks. Also worked with different partners like Jack Ma Foundation early at the beginning of this outbreak to provide testing kits to member states. And during this time, we provided more than 1.1 million tests to member states in addition to IPC supplies as well. And this is the structure for AFCOR task force. As I mentioned, this is a continental structure to coordinate, collaborate, and communicate between member states to prepare member states and support them in responding to COVID-19 pandemic. At the top of this structure, we have African Union Bureau composed of heads of states, 5 heads of states, 1 represent each region, in addition to African Union chairperson and Africa CDC director. And this African Union Bureau gives strategic direction for African Union Commission about the preparedness and response to this COVID-19 pandemic. Then we have 3 ministerial committee, one of them for health minister, another one transport and logistic minister, third one for ministers of finance. Then we have Continental AFCOR steering committee and 7 technical working group give technical guidance for Africa CDC regarding the response to COVID-19. One of these technical working group focus on surveillance, another one clinical care management, infection prevention control, supply chain and stockpiling, laboratory diagnosis, risk communication, research standard. And we are working closely with different regional health coordinating committee for East Central, West, North, and Southern Africa. Then to take you quickly at the beginning of this pandemic, how Africa CDC moved different resources to support different member states. For example, for surveillance, early in February, Africa CDC managed to provide training to more than 21 countries with more than 50 participants. This is training of trainer. And for this kind of training, we involved not only ministries of health to strengthen the point of entry and also event-based surveillance, but also we included airline companies as well. And for laboratories, early in January, no countries in Africa have the diagnostic capability. Early February, we have only 2 countries in Africa able to conduct COVID-19 testing, South Africa and Senegal. Then Africa CDC in collaboration with other partners, by the end of February, we managed to provide capacity building for 43 countries with initial test kit to support them to conduct COVID-19 testing. The same for infection prevention control. During the months of February, we managed to support 23 countries, provide training of trainer for IPC guidelines for COVID-19 testing. And we have more than 45 participants from different countries in the continent. For risk communication and community engagement, during February, 25 countries have been trained on training of trainer for risk communication and community engagement related to COVID-19. Then we started later clinical care management webinars as well. So far, as of 13th of November 2020, Africa CDC managed to provide different kind of training, either personal training, in-person training, webinars, and virtual training. So far, in laboratories, more than 20,000 persons joined our webinars and in-person training and virtual training. Surveillance, more than 5,000. IPC, more than 22,000. Risk communication, around 500. Case management, more than 11,000. Public health UC, around 5,000. For laboratory tests, Africa CDC managed to distribute more than 6 million tests in the continent. Mask, more than 10 million. Southern genome sequencing, more than 25. Equipment provided to different member states. Protective suits, more than 500. Dexamethasone, more than 1.8 million pill provided to the member state. Face shield, more than 7,000. This is in addition to ventilator, thermoscanners, and goggles as well. Our rapid responders and community healthcare workers are across the continent to support member states. We have more than 9,000 community healthcare workers deployed to support member states in contact tracing and also risk communication. We have around 196 technical experts across different countries in the continent to provide technical support to these countries. For Uganda specifically, we managed to provide different kind of training for public health experts from Uganda. This include laboratory diagnosis, infection prevention control, surveillance and contact tracing, risk communication, and community engagement. We deployed in Uganda around 950 community healthcare workers to support contact tracing. This is in collaboration with AMREF to support Ministry of Health and contact tracing in Uganda and risk communication and raising the awareness of the communities. For IPC supplies and lab test kits, so Africa CDC managed to provide more than 300,000 masks to the country, more than 16,000 protective suit, face shield, more than 12,000, laboratory tests, more than 280,000 test kits, viral transport media and TWAPs, more than 35,000. Another initiative for Africa CDC is PACT initiative, Partnership for Accelerated COVID-19 Testing. We launched this initiative early at the beginning of the pandemic. This is almost around April. And our target during this time, within a month, we need to push the agenda of testing in the continent. We noticed during this time, not enough testing is conducted in the continent. So we need to accelerate the COVID-19 testing. Our target within a month to provide more than 1 million tests. And within 4 months, the continent to conduct more than 10 million tests. Already exceeded this target. As I mentioned, we have more than 20 million tests conducted in the continent, and Africa CDC provided more than 6 million tests to different member states. And also to have pool procurement process to help member states to acquire COVID-19 testing and IPC supplies, and also to engage with the countries and encourage the country to deploy more than 1 million community health workers for contact tracing, in addition to adopt new technologies for surveillance. Recently, also Africa CDC launched Africa Against COVID-19 testing, saving live economies and livelihood. And we have 3 main pillars under this initiative, because it's important for the member states, yes, to support them to save lives, but also countries become overwhelmed with the economic impact for this COVID-19. So this initiative focus on how to save lives, in addition to also help member states to start opening their economies to decrease the burden of this economic impact for COVID-19. This is why we launched Trusted Travel Platform to start helping the countries to open their border. And this is online platform. When you use this platform, you'll have access about what kind of travel restriction measure imposed in these countries. Also, we have data about the labs in the countries that accredited for COVID-19 testing. And also in the second phase, airline companies, the countries, the lab, in addition to the person as well, will have access to this COVID-19 testing result to facilitate the moving across the continent. Also, how to protect schools, especially we are starting now the academic year for the schools. So how to strengthen the surveillance and also assess the risk and have IPC measures in place to prevent further spread for COVID-19 testing within the schools as well. And also to support country to share data to help them in between the inter-economic region to help them taking informed decision about having the economy regained back again. And we shared the consideration for opening the economies and have guidelines for member states regarding this issue. Another initiative regarding the vaccine development and access strategy for COVID-19. And this strategy focus on 3 main pillars. The first one, focus on clinical trial to map the existing clinical trial in the continent and sharing the information regarding these clinical trials. Second one, to ensure that Africa have access to sufficient vaccine supply, access, financing, and procurement, and also to map the manufacturing capacity within the continent as well for COVID-19 vaccine. And third one, focus on the regulation, delivery, and logistic related to this vaccine. In the continent, we are a continent of 1.3 billion. Our estimation, if we need to cover 100%, we need around 3 billion COVID-19 dose. To target 20% of the continent, we need between $5 to $7 billion. 60%, we need 16 to 21 billion dollar. For 100%, we need between 23 to 35 billion dollars. And finally, what is next? We continue for the preparedness and response for the second wave and supporting member states. Our IPC team and lab test, in collaboration with different partners, we have estimation for what kind of supplies needed for the second wave, and we already start the process for procurement of IPC supplies and test kits to support member states. And we'll be continuing the PACT initiative to increase the COVID-19 testing, tracing, and treating capacity in the continent. We'll continue with the vaccination to ensure that the continent will have access to COVID-19 tests, and also the logistics and supply needed to ensure the delivery of these COVID-19 tests are in place. This is in addition to continue supporting member states to ensure that we're not only saving lives, but also saving economies and livelihood. That's it from my side. I'm happy to receive any question. Thank you.
Thank you so very much indeed, Dr. Wessam. Phenomenal. I think this presentation has actually really highlighted a lot of the things that have actually happened. I'm just thinking right now, when I look at the projections from 2 labs being able to test to 43 labs being able to test, or 43 countries being able to test in such a very short time, that's a huge networking, a huge pooling of all the resources on the continent, and real tremendous coordination from Africa CDC to be able to make that happen. And all the other stats that you shared, I think there's tremendous effort from many people other than those of us who are speaking this afternoon. There is tremendous effort from lots of ministries, lots of organizations out there to be able to make this happen. Just before, I have a couple of questions that are coming up. We're going to take 3 questions, and hopefully the 3 questions we pick would go to each and every one of you. Let's see. Is that a comment or a question? First one. I says, thank you, Susan. I think Dr. Nabadda, this is to you. Thank you, Susan, for this presentation. If COVID-19 diagnosis is at the moment focused only on priority testing, what are the likely strategies that need to be implemented to ensure Uganda government can absorb this multiple novel technology within the nation's healthcare system post-COVID-19? That's directly to you, Dr. Nabadda. Did you hear me?
Yes, I did.
Okay.
Yes, I did.
Good.
So thank you very much. In Uganda, and we are aware that very many innovations are coming up, especially point of care testing. A number of point of care technologies are coming in, and as our policy in Uganda, whichever technology comes in must first be validated. So we have a number of them being validated because we know if they perform well, they can be point of care technologies that can be placed and we increase access to testing. So currently there are a number of POCs that are being validated in country, and if they perform well, this will take us a long way of deploying them at the lower health facilities to increase the access to testing. The issue why we are doing priority testing is because of mainly the reagents. We are mainly doing PCR testing, and the supplies are not coming forth as we expect, but also the funding is not as expected. So we had to scale down and do priority testing. But as RDTs are coming on board, this will increase our testing. But with the new technologies that we are also validating, it will go a long way of moving away from priority testing and we move into mass testing. Back to you, Chair.
Thank you. It looks like you have the third one, but let's go with Wessam on the second one. It says, we have noticed the number of candidate vaccines in the development pipeline continues to increase. Are there any programs currently underway to strengthen the partnership with vaccine developers to identify potential and appropriate trial locations within Africa? I think that goes to you, Wessam, please.
Yes, as I mentioned, we have Africa Joint Continental Strategy for COVID-19 vaccine in the continent. Under this continental strategy, we have a steering committee looking forward for these issues that you highlighted about what kind of vaccine in the pipeline, communication with the pharmaceutical company producing this kind of vaccine, not only for acquisition and having access to this vaccine, but also to have this kind of technology available in the continent. And we'll be giving priority for the companies that will make this technology available in the continent for production. On the other side, we are mapping different clinical trials are in place in different countries in the continent to see the progress in this clinical trial and know the result of this clinical trial for different vaccine candidates, in addition to mapping the capacity in different member states for vaccine production, so we can build on these existing capacities and to create the link between different companies that reach to successful vaccine and to the countries in the continent that have this production capacity. So this is the work in progress so far. Over to you.
Thank you. Dr. Nelson, I'm going to twist this third question and make it for you because it's actually structured for Dr. Nabadda, but I'm going to twist it and make you answer that one. And actually the question is, based on the support that CDC has given MOH thus far and a number of things that you highlighted, whether it's the transport system or it's the testing, all the support that CDC has given MOH thus far. The question here is, what do you think priority focus should be as we go forward?
Great. Well, thank you, Professor Kilian. And I might also take a stab at the third question a little bit more generally. And I think, you know, we have a lot of the building blocks in place. And I think that is a function of Uganda's efforts over many years, but as well as support that they've received from CDC and others to build laboratory systems, to build emergency operations systems, to build a workforce, data systems, et cetera. Going forward, though, I think, I'll be honest, number one, we do need to find greater efficiencies because I think COVID-19 isn't going away anytime soon. I think we also really need to look at how we invest in some more sustainable approaches. And by that, I also mean, I think what I see at Ministry of Health, and that includes our colleagues at CPHL, is, you know, fatigue has set in. People are getting very tired. They'd like a break, but this virus isn't really taking a break. So, you know, that could be things such as rotating some of the key personnel out of the incident management structure. I think already I've seen, you know, we used to have daily meetings, and now in some cases we're going to meetings a few times a week or once a week. And I think that's appropriate because I think we do need to switch from a sprint to a marathon and think about how we can do this more sustainably. But I also think we need to continue to innovate. You know, we're going to see rapid diagnostic tests. We're going to see new vaccines, new tools in the toolbox that we need to be able to adapt and roll out.
Thanks very much indeed, Lisa. There is one which I really, I'm going to try to throw out there, and any one of us would try to pick on this one. The question here is, do you think antigen rapid tests will be used in Africa? Dr. Nabadda, you want to start on that, and then Lisa, and then Wessam, and then we'll close on those. Do we think that the rapid antigen test is going to be used in Africa?
Thank you, Prof. As I already mentioned in my presentation, in Uganda, we've started rolling out the antigen rapid test. You all know we got guidance from WHO that we can start to use them, but use them in particular populations. So as Uganda, we've started rolling out in a phased approach after we validated some of them and they were passing the cutoff level of WHO that is above 80% sensitivity. So it's yes, in Uganda, we're using the antigen-based RDTs with guidance in particular populations.
Lisa, would you take a stab on that? What's the big picture? What are you thinking? What do you see?
Sure,
Yes.
sure. Just so as Dr. Nabadda has said, I think, you know, 6 months ago when we had very few cases in Uganda and we had the ability to do PCR tests and our positivity rate was below 1%, you know, there was some concern about using RDTs in that setting where the sensitivity and specificity weren't as high. I think number one, we're in a different phase in Uganda of a lot of community transmission. As Dr. Nabadda has talked about, we've revised our testing strategy. And also we've gotten more data on the performance of the RDTs and newer guidance from WHO. So I think at this point, we are starting to use, and I think it's appropriate that we use RDTs in certain populations to screen for active disease and in certain settings where doing PCR-based testing is more difficult, such as congregate settings or borders, et cetera. So I think we've evolved with the evolving science, and that certainly makes sense in the context of Uganda.
Thank you so much indeed. Wessam?
Yes.
What's the big picture for Africa?
Yes, for the rapid test, especially the antigen based. So Africa CC recently on Thursday, we conducted a training of trainer, and this is included 14 countries. This was happening in Zambia last week, Thursday and Friday last week. This is to provide the training about using this antigen rapid testing. Our target in collaboration with the different partners to provide for the continent in the coming few months around 6 million antigen rapid tests to be available in the continent. This is to push the agenda for the testing in the continent, and we issued guidelines for antigen rapid tests and also having training materials, and we make it available to member states to conduct this kind of training for antigen rapid testing. Over to you.
Thanks so much indeed. There's still so many questions coming up that we've gone much longer than we had actually planned to go. At this point, I just want to please extend my sincere thanks to Dr. Nabadda, Dr. Nelson, and Dr. Mankoula for being a part of this. And to all of those who still have questions on the chat, I'm just taking my eyes up and looking. We're going to try to provide them with a response. And just to conclude, the World Bank's response to COVID-19 in Africa, we saw some of the numbers that Dr. Mankoula has shared with us and Dr. Nelson has shared with us. The World Bank intends to put another 50 billion just for African countries alone. And its priority areas is saving lives, protecting poor people, protecting and creating jobs, and building back better, So that's what the World Bank is going to be looking at. And so there is $50 new billion that need to be spent in this area. I thank you all for joining us today. It has been a phenomenal show. Look forward to seeing you. We're not going to see you anytime soon. Our next webinar is going to be on the 1st of February, 2021. Till then, I want you to please stay safe, continue to check your temperatures, wash your hands with running water and soap, use the sanitizer in the absence, have some kind of face wear, face mask, protect your face, and social distancing still has to be maintained.